Well, good afternoon. Thank you so much for having me here. And Representative, you're on to me. I was trying to make sure I didn't repeat what Dr. Collins has talked about. She did such a fabulous job of providing the overview of particularly the preventable nature of chronic disease in our nation. So in recent years, the issue of prevention really has made national news. It's becoming an increasing focus in healthcare conversation. It's a huge issue for business. Time magazine published 5 separate cover stories on health and wellness, and Americans care about this. This is what, there's hardly a family that doesn't escape diabetes, cancer, heart disease, arthritis, the list goes on. It's really something that makes a difference in our lives and something we've seen changes in, as Dr. Collins has outlined. So I work for the state health agency in Kansas. I actually live over here, though, so I spend most of my time in the car. But I also serve on the board of directors for the National Association of Chronic Disease Directors. And I'm actually representing the National Association today, but sharing with you some of our experiences in Kansas as it relates to the issues that Dr. Collins has laid out and how the states can serve as a resource to you in the legislature or the state health department staff. We're a member-based organization that is governed by a board of directors, and our membership is primarily state health department employees who work in chronic disease prevention and control. So that includes diabetes, cancer, arthritis, school health programs, asthma, oral health, tobacco use prevention, healthy eating promotion, physical activity promotion, and the like. We also have a growing number of members who work outside of the health department and hold associate member status, because as we deal with chronic diseases, we find how critically important it is to work in partnership with other organizations and interested parties across the nation. So this afternoon, what I'm hoping to do is give you some ideas about how you can capitalize on the expertise that you have in your own states and what they bring to the table, because every state has a chronic disease director, so use them. If you don't know them, reach out and ask for help on that. So here's how the states kind of think and work. You know, what keeps state chronic disease directors up at night? I want to start with the staggering prevalence of cancer, diabetes, heart disease, hypertension, stroke, mental disorders, and lung disease. In this particular slide, you can see where just those 7 common chronic diseases number over 162 million cases of chronic disease. And this chart is ranked by quartiles. So you see that the blue is being best, green is next, orange third, and red at the bottom. So for states, you know, we kind of do 2 things at once. We really talk to each other a lot in state chronic disease programs. We learn from each other. When somebody tries something, they're implementing something that becomes documented as evidence-based over time, we're all over that because we're looking at how we might be able to implement that or adapt it to our own states, because every state is different, and we have not everything. What works in New York, I can tell you, doesn't work in Kansas all the time, but some things do, and similar vice versa. So, but we're also kind of competitive. You know, we're competing for Dr. Collins' money when we write those grants. But as we look across the nation, we're really looking at best practices. We're looking for promising practices. We're looking for the kinds of interventions that would really make a difference in health outcomes in our states. So to put those huge numbers into perspective, I think it's the equivalence of the chronic disease as #1 cause of death and disability in the U.S. is equivalent to the number of Americans living in the 40 smallest states in the Union. So if you took everybody with chronic disease and put them in one place, they would equal the population of our 40 smallest states. And as elected officials, you might also recognize that this is also more than the number of Americans who voted in the last presidential election. It is really prevalent, and I want to talk a little bit about how that came to be. States actually play a very unique role in this federal, state, local partnership for public health. And our unique role is in data collection to describe the population health. When we look at vital statistics data, the death data alone, you know, what people die from, what's on the death certificate, we're really only seeing the tip of the iceberg. However, states also focus on what's underneath that iceberg. What is below the waterline? What is driving the death rates? why are the driving forces behind death rates? What makes some groups of people subject to dying early, being sicker, developing preventable disease? In the news, we hear a lot about the growth in prevalence of diabetes, and more recently in prediabetes, which is even bigger than diabetes in some ways and holds more promise for reversal. But we haven't even begun to see the tip of the iceberg with regard to diabetes and prediabetes. And prediabetes, as you may know, is actually a clinical condition that is based on measures of impaired glucose metabolism. It's when a person gets not to full-blown diabetes, but well on the way. So if current trends continue, 1 in 3 children born today will develop diabetes at some point in their lives. And it's one of the most expensive diseases. I know in our state Medicaid program, it's the one that policymakers are really focused on because of the tremendous cost of caring for diabetes. 1 in 2 children will develop diabetes in their lifetime if they're Hispanic. So what we do in the state is we explore through population health surveys the prevalence of risk factors and behaviors that predispose people to certain chronic conditions. Every state conducts a behavior risk factor surveillance system, and when you combine the data from all those states, which is what CDC does, we provide our data to CDC and they aggregate it to provide national estimates. It is actually the world's largest continuous running population health behavior survey in the world. And the data is what helps us to drop below the water level and begin to see how we can make a difference in the projectiles for chronic disease. So Dr. Collins outlined the progression of diabetes and as it follows the obesity epidemic, and truly this diabetes epidemic is right behind the obesity epidemic. And this slide is showing kind of where we stand now, and as she noted, by 2012, which is this data, even Colorado had slipped off, and they are over 20% obesity prevalence in the adult population. So overall, about 30% of the adult population are obese, and that is a doubling since 1980. With children, the rates of obesity have tripled since 1980. And if we go back to the obesity rates of 1987, that would automatically reduce our healthcare spending by 10% less. So it has made a difference on our expenditures as well. And while the human cost is enormous, the economic cost is also very great. The cost of treating these conditions, even without taking into consideration the many secondary health problems they cause, are in the billions of dollars. And it's probably the impact of lost work days and lower employee productivity that results in the economic loss of the United States of over $1 trillion, and that's back in 2003 dollars. One of the things that employers note is presenteeism. And most employers will list chronic conditions as the biggest reason for presenteeism, which is defined as being when people come to work but they're not as productive. They don't feel well. About 21% of workers report that they have gone to work despite being sick or dealing with a non-work issue 6 or more days in the last 6 months. And I think that's one of the reasons we find, at least in our state, we're finding more requests for assistance from employers across the state, and business health coalitions are growing in membership and in scope to deal with some of these issues. Because businesses have to take into account not just the healthcare costs of their employees, but also the spouses and dependents of those employees who are covered under the business plan. And they're dealing, as I mentioned, with high rates of chronic disease in the workforce. Dr. Collins mentioned that 80% of the workers have at least one chronic condition, and over half have more than one chronic condition. When we conduct our behavior risk factor surveillance system in Kansas, our survey, we find it's just amazing the number of people that have 5 chronic conditions that they report through that survey. Obesity is one of the drivers of those costs. Looking back at the reason that people miss work, obesity, overweight, chronic disease are driving much of that. And in today's economically challenging times, investment of disease prevention, I think I might be missing, makes even more sense than ever before. But here's the good news. the vast majority of cases of chronic disease could be better prevented or managed. And as we do dive below the waterline, we find most chronic diseases could be prevented by focusing on three things, and Dr. Collins already mentioned those: stop smoking, eating healthy, and physical activity. The World Health Organization estimates that at least 80% of all heart disease, stroke, and type 2 diabetes, and more than 40% of cancer could be prevented with just improvements in those risk behaviors. So where is the key to prevention of chronic disease, and how can states truly impact that? That seems to be the growing question these days. So think about the fact, as you saw on previous slides, that heart disease became the leading cause of death, early in the last century. We have made huge gains in medicine to treat heart disease with the statin drugs, angioplasty, bypass surgery, all that stuff. However, despite these advances, heart disease is still the #1 cause of death. And not just because people die of heart disease when they're 105. We're talking younger and younger people are dying from heart disease and keeping it at the #1 cause of death. So there are things that need to be done despite the advances in medicine. When we look at the left on all the causes of mortality, our gene pool hasn't changed. But as Dr. Collins noted, the environment has had incredible changes on how we develop disease. So let me ask you a question. How many of you rode your bike or walked to school when you were in grade school? Yeah, okay. How many of your kids did? So that's a pretty big, if you're looking around the room, it's a pretty big difference. Our patterns have changed. How many cars did your family drive when you were growing up? Anybody have more than one? A couple, okay. And how many do you have now in your current family? We depend, the way the cities have grown, we depend more on transportation. So how many times did your family eat out? Every night? Who ate out every night? Okay. Well, you're not old enough. Okay, for this quiz. Okay, how about 3 times a week? Once a week? And how about now? How many eat at home every night? Carry-out does not qualify as eating at home. So you see our life patterns have changed, and these things make a difference, and I'll talk about that a little bit more here in a minute. But in our country, we have made impressive progress in medicine and treating disease, and we've invested millions of dollars, and none of us want to turn the clock back on the advances that we've made in those areas. But as you can see from the balance of the balance of cause is swinging. We've done what we can do for the conditions or the contributors to chronic disease that we don't have a lot of control over, but the behaviors that can be attributed to chronic disease, we invest in very little comparatively to the phenomenon or systemically changing the dynamics that lead to unhealthy behaviors that lead to chronic disease like heart disease and cancer and such. So when we look behind that trend, we find that population-based approaches have the potential to prevent 70% of premature deaths through measures that target the underlying risks, such as tobacco, drug and alcohol use, diet and sedentary behaviors. In fact, there's about 8 risk and behaviors in the circle there that drive 15 chronic conditions, which are contributing to 80% of the total costs for chronic illnesses in our country. But there are evidence-based strategies to address these, and I'm going to give you a few examples as we go through some of the state applications here. Okay, so we know it works. In general, this slide offers a pretty good framework for action at a state system level. So stabilizing the health of individuals, getting diabetes, that's to prevent emergency room visits. So getting diabetes in control, asthma in control, some of the reasons that people drive to the emergency room that could be avoided. We have the integration of mental and physical health services. I think you're going to be talking about that on the agenda tomorrow. And also the cost related to long-term care, delaying admission into long-term care, providing low-cost community-based options at the community level to support people in managing chronic disease. And then also just managing transitions between care providers and physicians. And this is an area that has really grown in opportunity for public health as we become more familiar with the interface between public health and primary care and continue to explore that. So what are some of the basic interventions? Environmental changes to support healthy lifestyles, facilitating public, private, and state and federal collaborations, celebrating best and sharing best practices, facilitating replication, which is something we do across states on a pretty regular basis, and rely on CDC to help in facilitating some of that transfer. And supporting health information technology infrastructure, which I think is just one of the real huge opportunities that we have in managing chronic disease and reinforcing from the clinical setting the importance of the primary prevention best practices that we're familiar with. So let's look for a minute. Going back to the causes, the circle with the 8 risk factors and such, when we examine the driving forces below the iceberg to help us in identifying ways to change the projectile of this continued escalation of chronic disease, we continue to learn that the more comprehensive our approach, the better the health outcomes. So take physical activity, for example. I asked you about walking to school. What we found is that our data tell us that how people move from place to place affects their physical activity levels and thus their health status. So, for example, if the store is up there, I don't know if you can see this pointer or not. If the store is less than a mile from home, about 40% of us walk. But if the store is 3 to 4 miles, then about 1% walk. It's kind of the same for work sites. If the store is less than if work is less than a mile away, then about 35% of us walk to work. But if it's over a mile away, 3 to 4 miles, then it drops again to 1%. And similar for social outings, going to church, whatever you do in your day, when you think of where you live, work, and play. If it's close, we walk. If it's not, we don't. But then think on the opposite, the flip side. Physical activity helps control weight, but it has other benefits. Physical activity such as walking can improve health even without weight loss. People who are physically active live longer. They have lower risk for heart disease, stroke, type 2 diabetes, depression, and some cancers. So improving spaces and having safe places to walk can help more people become physically active. And it doesn't always require tearing down buildings and rebuilding streets and neighborhoods, although that can happen too. We actually have an example of that coming up here in Lawrence, Kansas, which is just a little further west of Kansas City, where they just announced plans to be building a multi-generational community where seniors and young families and singles and others work and have work sites and social kinds of access to community, church, and all that. So rather than segregated neighborhoods like gated senior communities and such like that. So it's kind of, those are popping up around the country, and I was interested to see that there was one right here. And the other thing that we're seeing more of, we do as a state health department, we provide small amounts of funding to local communities that have had great success in boosting the economics of their community and getting people out to walk by hosting farmers markets. We did that actually in downtown Topeka, which is the state capital, where we worked with downtown employers and set up a midweek farmers market on Wednesday morning. And we have thousands of downtown employees, about 30,000 people work within a mile radius of downtown. And remember that mile cutoff where people walk or they don't walk. So we have thousands of people that visit the farmers market, and it's as much a walking destination as it is access to fresh fruits and vegetables. And, by the way, it was good for the pocketbook of Topeka because they estimated I've got, my data's 2 years old, we didn't estimate it last year, but over $20,000 in new tax revenue as a result for that little initiative. We also, when thinking back to that slide with the bars, the environmental changes and some of the context that Dr. Collins talked about, another example, we work with, most of your states do have governor's councils of some kind. They might be funded differently or associated with the national group or not. In ours, we have a governor's council on fitness, which is an excellent example of public-private partnerships. The members include business, medicine, academia, public health, third-party payers, philanthropic organizations. They're all volunteers. They're not paid for their work. But last year at our obesity summit, our governor gave them the challenge to set up a physical activity champion network across the state. Now, as elected officials, you might appreciate his special twist on the rules to set this up. We were thinking, oh, that's a good idea. But his idea was to identify volunteers that would agree to serve as physical activity champions, one in every county, or a group in every county, as it turns out, because as we invited them, they said, oh, can I bring so-and-so with me? And they will be convening in Topeka here in a couple weeks. But their goal, the council's goal, is to increase, our data show us that only 35% of Kansas adults meet the recommended guidelines for physical activity for aerobic exercise. So their goal is by 2014, we will have 105 physical activity champions connected to the 105 counties and the 4 sovereign nations in our state to help promote physical activity within their local communities. Some of the things that they will be doing, as I mentioned, they'll be convening in a couple weeks. We have, so far, over half the counties have identified a champion. Most of them will be joining us in Topeka in a couple weeks along with other partners. The champions will be the spokespeople at the local level, serve as a liaison to the Governor's Council on Fitness. They will make connections with local leaders like mayors and other elected officials to promote the Kansas Move Across Kansas competition, which is an online web tool for tracking physical activity. There's a lot of excitement generating over this, and we actually are studying this as a quality improvement program in our state. We did get a small grant from the Association of State and Territorial Health Officers to study the effectiveness of the impact of setting up this voluntary network. But the kinds of things that they've expressed interest in is doing exactly what Dr. Collins was talking about, and that is to promote safe routes to school, walking school bus, using and promoting the park system, meet me at the park for a walk on Saturday morning kind of things. And these are folks that are really wanting, they don't do physical activity is not part of their regular job, but they are really wanting to make a difference as they see friends and neighbors suffer the impact of chronic disease as their lives. So another way, one of the other things we wanted to talk about, I'm thinking back to that bar slide, is how we share best practices. Policy is one of the areas that states really do learn a lot from each other. And tobacco control is one of the areas that Kansas has not been out front on. So we've learned a lot from states that have developed the evidence base for what works in tobacco control. Evidence-based public health efforts in synergy with policies can be incredibly effective. You've all seen the drop in deaths from vehicular crashes when comprehensive seatbelt laws were enacted in your states, for example. This is the Kansas story on tobacco use as it was affected not only by the public health and public education efforts of the state health agency, and likewise at the local level with our coalitions that were focused on reducing use of and exposure to tobacco, but the policies with hard evidence of reducing tobacco use of Kansas adults and youth were in place. So what you can see there is as our trend line goes down, it's further impacted by the tax increase in 2001 and again slightly in 2002, and the Clean Indoor Air Act that we passed in our state in 2010. So I think we were on your slide. But as you can see, when you look at that trend over time, the high school smoking rate fell about 46% actually from 2000 to 2011, about a 9-year time period. And estimates of the prevalence of adult cigarette smoking fell from 21 to 17%, which is almost a 20% decrease. So our legislature's commitment to the issue complements the ongoing work of partners to educate their communities. And certainly our communities have stepped forward and taken a lot of action there with some of the other tobacco control issues, like smoke-free housing, smoke-free parks, reducing further the exposure, because it is flattening out in adults and children, and tobacco use is still the #1 preventable cause of death in our country, not just in Kansas. So we consider the legislature a vital partner in the collective work to improve the health and safety of people in our states. Well, we also have a lot of partnerships with federal partners, be that CDC, HRSA, CMS, and others. Right now, CDC is assisting states in the area of tobacco control in enacting what we know works. As I mentioned, tobacco use remains the #1 cause of preventable death. There has been an increased use in our tobacco quit line in our state, and we appear to have reaped the benefits of the CDC TIPS campaign. And I'll show you a couple slides here in a minute. What the quit line does is provides 24/7 counseling from master's degree counselors in social work, psychology, or other behavioral health fields. They're very skilled culturally and competent in principles of motivational interviewing for inducing behavior change. More than 50% of the Kansas quit line counselors have 3 or more years of counseling, so they do a good job. And we've noticed that there really is a high success rate. When a callback survey, 7 months after registering for the quit line, 29% of the users reported being tobacco-free for at least the past month. So they are having success, and as you know, it takes sometimes more than once to have a successful quit. And this is what our use looks like. This depicts the increasing usage of the quit line overall, but you'll notice those peaks. Those are directly correlated with media education campaigns, such as the Tips for Smokers and other state-initiated campaigns. So we've done a lot with that. The other thing we've done is, because our smokers are becoming younger, we also have enacted not just the telephone counseling, but a web-based counseling, and that's the yellow bars there, which is becoming more and more popular, particularly as younger people attempt to quit use of tobacco. And public education works. We now see in the data that we collect on the Health Risk Behavior Survey that over half of Kansas smokers report they have tried to quit within the last year. So we're also seeing, as I mentioned, opportunities in information technology. And this is another area that states have done quite a bit of work with in state chronic disease programs. So let's go back to heart disease for a minute. #1, it's still the #1 cause of death. With data reported in 2011, heart disease, stroke, and other cardiovascular diseases were among the leading causes of death and now kill more than 800,000 adults in the U.S. every year. But 150,000 of those were under the age of 65. So these diseases were also 2 of the leading causes of health disparities in the U.S., and treatment of these diseases accounts for about 1 in every 6 U.S. health dollars spent. And there's 2 main reasons: high blood pressure and cholesterol, which are common, they're deadly, but they're preventable. Nearly 2 out of 3 adults with high cholesterol and about half of adults with high blood pressure don't have their condition under control yet. But there are proven strategies for that, and what we've been working with, beginning with our diabetes program and expanding with our cardiovascular program, is working with clinical providers in implementing the chronic care program. This is an area we've actually made really big strides, I think, in the last 10 years. So it's working with healthcare providers to increase quality of care, implementing their quality improvement practice in clinical settings. We're now expanding, as I mentioned, to connect the providers with community resources. So we're expanding outside the systematic changes within the clinic setting to connect with the community as well. So in the areas of systems development and quality improvement, the knowledge and expertise that providers have to actually treat the condition are a wonderful match for the skills that, ooh, that's kind of dark to read here, the skills that we have in the state health department with quality improvement. So as we're working on that, we're actually working with providers to implement those referral systems that Dr. Collins mentioned in sending people out to YMCAs for diabetes primary prevention, cholesterol screening, hypertension screening, and such. So with all the success we had in diabetes in the initial areas, we've added the indicators for heart disease and stroke as well. And what that amounts to is working with the providers. They used actually a Microsoft Access database, some public domain software called CDEMS, Chronic Disease Electronic Management System. That's what we started with 10 years ago when nobody had electronic health records. And the providers were like, I don't know about this, but they implemented the CDEMS. They were able to track electronically the progress of their patients with diabetes and really were sold on that. And a couple of our providers have told us that that's really what motivated them to make the jump into electronic health records. So some of the providers in our state that were the first in electronic records actually started as part of that Diabetes Quality of Care project. And what is able to do is the information is the providers can export that in Microsoft Excel to the state health agency, and we're able to analyze that and send it back to them so they can see what their prevalence or how they're doing on standard of care for, in diabetes, for example, every time taking off shoes and socks, appropriate eye screening, blood pressure, that sort of thing. Whoops. So we work with them. We provide, the expertise in quality improvement and work with them on their Plan, Do, Study, Act. The providers clearly have expertise in the disease condition and how to treat that. But what we've seen over time, and we have probably about 65 clinics that have been working with us for the last, almost 10 years now, and what they have found is they've been able to make adjustments in their practice procedures to improve the quality of care that's leading to better outcomes of their patients. So as a result, individual clinics reported improvements and innovations in a number of areas that we're tracking for heart disease and diabetes. Well, fast forward now to 2013. We started this in 2003. And we all recognize the world of health information is changing, and it's changing fast. New technologies are required to meet the growing demands placed on the healthcare system. And as the use of electronic health records explodes, new sophisticated approaches to collecting and sharing vital quality improvement data are needed. So the diagram I described in the first slide depicted how the Kansas project used CDEMS, and now we're at a point in time where our current work, many of these providers are in the process of implementing electronic health records, or they've already done that, and we have been able to provide CDEMS into an EHR interface, which provides a unique opportunity to continue what started with the implementation of CDEMS. And what we're doing now is mapping our new system to electronic records so that we can produce those same quality indicator reports that providers have become accustomed to. So we've been working to migrate the CDEMS system to something we call a Catalyst. It's a vendor product. And while this migration was required because CDEMS just, it's old architecture, it doesn't work that well with the electronic health records. It was critical to provide the same quality information and reporting that had been available for the CDEMS, because that's really what the providers were building their quality improvement practices on and making adjustments in their protocols. So we worked with our contractor and his team to meet the specific needs of our state and the providers that we are working with to develop essentially a central registry of patient and clinic level data on diabetes, hypertension, hyperlipidemia, and other chronic disease indicators. And what Catalyst can do for us and for the providers is to link the EHR systems from all clinics who have participated in our quality of care project over the years, but it provides a more streamlined approach to data entry. They no longer have to enter data separately. It's just pulled out of the data systems. It's all de-identified, aggregate form only, so there's no issues with confidentiality, but it has a tremendous ability to assist providers in implementing improvements. We'll have our first data coming out of that interface with the EHRs by spring, so we're pretty excited about that, and we have a number of clinics that have jumped on board with that. So I'm going to stop there. I want to give credit to the National Association of Chronic Disease Directors and Partnership to Fight Chronic Disease, who helped put some of these slides together. That gives you a little bit of an idea of how states are working and how the work of the Centers for Disease Control and other federal partners complement the work we have, the kinds of expertise and opportunity that you all have to tap into chronic disease staff in your state health departments. And I will stop there and see what happens next on this agenda. Thank you so much.